I now have the pleasure of introducing myself and me. Thank you. I want to say I'm really inspired by the creativity and determination and passion that I've heard over the last 2 days. It's really, it's energizing, and it gives me a lot of hope and a lot of ideas about what we can do. I'm going to close the session by offering my own thoughts on how we can take what we've learned this week about combination prevention for HIV and apply it to other health issues that disproportionately affect the communities we work with. Any mistakes or controversial statements I make should be attributed to me alone, but the aggregate of the work I'm presenting is really led by a lot of other people in the room, in particular Olivier Ferlat from UBC and Aaron Purdy from Health Initiative for Men, and Mark Gilbert from BC Centre for Disease Control. And also a growing collective of individuals working with queer communities, some of whom are listed here. This group started meeting every quarter 2 years ago. It's an LGBTQ mental health roundtable. It's a very creative and clever bunch who believe that if we continue to get together and share ideas about queer mental health, we will eventually forge a strategy, maybe one that we can present here next year. So I'm going to start with statistics because I want to give you a sense of the severity of the issue I'm discussing. If you've seen me present before, you've heard this plenty of times. I spent much of my PhD compiling data and sharing it with others, and in summary, we now have nearly 100 published primary data, published papers that establish a consistent disparity in suicide risk between gay and bisexual and other queer adults and heterosexual adults. So about 1 in 5 of us have tried to end our lives. There's an enormous amount of published evidence demonstrating this disparity, 5 systematic reviews, but very little understanding of how to prevent sexual minority suicide, and several of us think that's unacceptable. Suicide is the most severe case of a mental health disparity affecting sexual minorities, but depression and anxiety are perhaps less severe in outcome, but much more common. 1 in 5 of us is currently experiencing depression. That's twice the rate of the heterosexual population. Together, the excess burden of mental health struggles borne by queer people, above and beyond what we would expect based on heterosexual counterparts, whether measured by deaths or doctor visits or daily life struggles, is enormous. So can this be prevented? Yes, this is a rhetorical question, but one without a clear answer. We have to ask this question. So I'm going to start, because I'm a public health nerd, with what we call the prevention pyramid. On the bottom, we have prevention. So in the case of HIV, this includes many of the things we've been hearing about at the summit this week: PrEP, PEP, sexual negotiation, sexual empowerment, stigma resistance. In the middle is detection or secondary prevention. This means HIV testing and diagnosis, which has been a mainstay of the HIV response for decades now. And on the top, treatment. Now, ideally, the proportionate attention is balanced between these 3 strategies so that we don't need as much treatment. We have effective prevention, then of course we'll always need detection and treatment, but less and less. So where are we at with mental health? Well, I would argue we have a fairly lopsided prevention pyramid. We have some investment in treatment, but proportionately few services available for primary and secondary prevention. Where does all of this fit in relation to combination prevention for HIV, the topic at hand this week? Well, first, we know, and Mark brought this up when he opened the summit yesterday, from Demick Theory, which is increasingly supported by empirical data from Canada and elsewhere, that the HIV epidemic does not happen in a vacuum, but rather in close relation with other epidemics, including the ones that I showed you earlier. In particular, depression, suicide, social isolation. The figure that I'm showing here was featured in the Provincial Health Officer report 3 years ago that described what's going on with HIV trends in gay and bisexual men in British Columbia. It's sometimes referred to as a snowball effect. In other words, things like social isolation, drug use, depression, suicidal ideation have a cumulative and additive effect on the sexual context in which HIV may be passed. They're inextricably linked to HIV prevention. The second connection to combination HIV prevention, and probably more important for the purposes of my talk, is because the answer to my earlier question, can these inequities be prevented, lies in the history of the HIV epidemic. The interventions that we've been discussing for the last few days are the product of an enormously successful advocacy effort that spanned decades. I started working in HIV prevention in San Francisco in 2002. I think of myself as a beneficiary of this effort. I'm continually impressed and moved by the history of the work that many of us in this room have done, and I'd like to suggest that we can build on this to address other health inequities that I showed you earlier. Here's how. I'm going to propose 4 pillars of prevention. They're not new, they're not radical. They've been well-established approaches to HIV prevention for gay and bisexual men, some of them for decades. In the case of mental health, I would say these pillars probably look less like the Temple of Isis, shown here, and more like the Temple of Apollo in Didyma. The pillars should be familiar based on the discussions we've had over the last few days, but I'm going to try to present where I think we're at in terms of addressing mental health prevention needs, but suggest where can we go based on what we've done in response to HIV. So first, access. In 2015 version of the Sex Now survey, we asked about recent suicide history, and we saw that 20% of Canadian gay and bisexual men thought about or attempted suicide in the last 12 months. This figure is even higher if we look specifically at HIV-positive men. It's higher if we look at Aboriginal men. It's higher if we look at trans men. Now, we might disagree about what the intervention should be that's offered to these men, but I think we would all agree that this group who are struggling with thoughts of suicide should minimally have a discussion with a provider or have the opportunity to have a discussion with a provider about what options are available to support them. But what we found was that 42% of them had not talked to a healthcare provider in the last year, not talked about suicide nor about depression or substance use, because we know often depression and substance use can later be associated with struggles around suicide. So where did they turn up? Well, this graph shows you the different points of recent healthcare and community access for these 42%. So 59% of them indeed have a family doctor, they just haven't raised the issue of their mental health. 29% instead sought care from a walk-in clinic. 13% did see a mental health professional, but maybe it was before they started experiencing thoughts of suicide. And for our purposes, the next 3 are especially important. Half of them had an HIV test. Nearly half were interested in this thing called PrEP. I don't know if you've heard of it. It's a drug that you can take to prevent HIV. I've been here yesterday. We heard from Mark Hall, today from Rajan, about how clinicians are scheduling visits every 3 months to check in with their patients who are on PrEP. So there are fantastic opportunities here within these visits for referral and support for depression and suicide. 16% volunteered at a gay health organization. There's no single place where we can reach these men, of course, but 88% came into contact with one of these services. We need a network, and in fact, we have one. If you live in BC today, you can get an HIV test at your family doctor, at the hospital, in the bathhouse, at gay community organizations. You can get tested online. There is an infrastructure here that we must leverage for other health outcomes beyond sexual health, and I'm very happy to say that I'm hearing about it at the summit this year. Thank you to Roberto for talking about the work you're doing in Max Ottawa, and I'll talk in a minute about the work that's happening at the Health Initiative for Men here in Vancouver. The second pillar is stigma. This is something we know well. It was the topic of the last 2 summits. It's also a major reason why 42% of gay and bisexual men who reported suicide ideation didn't talk about it with a healthcare provider. So a few years ago, I interviewed gay men who had attempted suicide as adults, and this is what one of the participants had to say. He said it was a balancing act, trying to fit in with family and friend circles. It was trying to fit in with the general public, how they perceived me. One of the things I can remember ever since I was a kid was always trying to please other people to compensate the secret of being gay. If this sounds familiar, this is something that John Pachankis opened the summit with last year. He talked about it extensively. There is a process by which we as gay, bi, queer, two-spirit people internalize these secrets. And we do a lot of work to keep other potentially damaging secrets from getting out. Pachankis called this the best little boy in the world theory. Boy George called it karma chameleon. Whatever it's called, it's fundamental to this intersection of sexuality and mental health. Again, we have cues for what to do, and we've heard about it over the last few years at the summit. Extensive interventions built here in Canada, including by the CBRC, in response to HIV. These are inspiring interventions. We have public art, we have social media, multimedia campaigns that serve to destigmatize topics and make participants aware of the lengths stigmatized groups and individuals go to in managing their stigma. And it's starting to happen with mental health as well. These are images from the most recent art exhibit of Still Here, a participatory photo voice project led by my collaborator Olivier Ferlat. This is a project that allows queer people who've experienced suicide or are affected by suicide to share their stories and experiences through photographs. It's a really incredible experience to go to one of these exhibits and hear people start to talk about suicide and depression in ways that I've never heard before. I mentioned earlier that we know that there are higher rates of suicide ideation and attempts in HIV-positive, gay and bisexual men. Still Here is currently recruiting HIV-positive men who've had experiences with suicide to participate in the next phase of their study. You can learn about it at their website here. The third pillar is literacy. So I want everyone to take a moment to reflect on whether you've ever discussed suicide with a friend who seems to be struggling. And I want to acknowledge that many of us feel unprepared to have these discussions when it comes to depression or suicide because of the stigma I was just talking about. So we're starting to get data from a number of Canadian studies that tell us about the literacy or preparedness of gay and bisexual men when it comes to HIV. Do they know what PrEP is? Do they know what PEP is? Do they know what TASP is? Do they know where they can get an HIV test? We have a finer and finer picture of the awareness and knowledge of interventions like treatment and prevention therapy. This month, Olivier and a team of collaborators are launching, actually not this month, this week, a quantitative survey. The idea is to give us a picture of what is going on, how prepared are we as queer, lesbian, gay, bisexual, two-spirit, and trans Canadians to respond to these elevated rates of depression and suicide in our community. So please take the survey and please get the word out. It's offered in English and French. Again, we have scaffolding from the HIV movement to help us along. 3 years ago at the summit, Mark Gilbert presented and then developed a sexual health literacy framework that is now being used to design new interventions, many of which were presented here this week. And we know that in many cases these interventions are working. So Take Time for Your Mind is a growing intervention at the Health Initiative for Men here in Vancouver, spearheaded by my friend and colleague Aaron Purdy, not Aaron Poirier. Take Time for Your Mind is an invitation to incorporate mental health alongside sexual and physical health. It's a resource that celebrates the resilience of queer men while honoring the practices they are already doing to take care of their mental health. It's also a resource to connect guys to tailored information about mental health and a point of connection to counseling programs at HIM and trusted partners. I've also been working with friends from the Crisis Center over the last year. We took 2 existing suicide prevention programs, Safe Talk and Assist, and we kind of queerified them and presented them to queer audiences. We've done 2 queer Safe Talks, 1 queer Assist. We're currently regrouping to think about what we can do with this intervention, how to take it other places. But I'm encouraged. There's little pieces of hope. There's promise here, things that I think we can bring back next year. Okay, the last thing we're going to talk about is integration. And as I showed you earlier, we can't rely on any one site to detect and prevent mental health struggles. But a clear and sensible place to start from these data is the STI clinic. And I'm not the first one to say this. I've heard it mentioned this morning. In fact, STI clinicians are already doing depression and suicide prevention work. They're already doing it. I know they are. It's not always formally counted. It's not always formally acknowledged, but we need to start to measure it and understand it. So for my postdoc, I'm working with nurses, physicians, and administrators across a variety of STI clinics in BC to understand what are all the different models we can use for sexual mental health service integration. And we've just wrapped up a waiting room survey with 1,115 clients of 6 STI clinics here in Greater Vancouver that predominantly serve queer populations. And what we found was that 39% of clients walking through the door reported a mental health need. We described this as having a self-perceived need, mental health need, about which they wanted to talk to a clinician. So this is people who are ready to talk. They're ready for action. 39%. Most commonly, this was depression and anxiety, but you can also see that substance use, partner violence, self-harm, and suicide came up a fair bit. 72% of these clients have not yet talked to a provider about it anywhere. So we think this is a fantastic opportunity to reach some of those queer men I showed you earlier who may not be opening up to their family doctor due to perceived stigma. I just had a conversation before the session with some nurses from one of these clinics who are thinking about how are they going to implement PrEP in the coming months and thinking about when will these issues come up when someone comes in asking for PrEP? Should they be addressed at the same time or maybe even before they get on PrEP? So returning to the concept of combination HIV prevention, what I'm proposing is that the syndemic pathway be routinely included and addressed in all of our HIV prevention and detection interventions, including PrEP. This means developing new and scaling up existing interventions that deal directly with things way far back on this pathway, social isolation. depression, anxiety, problematic drug and alcohol use. These interventions will not only pay off in preventing HIV, but also suicide, not to mention outcomes like care and treatment for people living with HIV. I hope I've convinced you that effective combination prevention requires not only a combination of HIV technologies, but a combination of venues and a combination of outcomes. And I look forward to seeing how far we get with this combination strategy when we reconvene here next fall. Thank you. I know it's just after 5, but facilitator's prerogative, I'll take 1 or 2 questions.
Hi, Travis. My name is Sarah. I work at YouthCo. Thanks so much for your presentation and the work that you've been leading here in Vancouver. One of the things that I was wondering if you could reflect on a little bit is what role might we imagine for peers in this work in scaling up combination prevention? There's a number of super successful, really amazing peer-led programs, both at YouthCo and other organizations in the province and across the country. So I was just wondering if you've thought about that at all, or if that's something for next year's summit.
Yes and yes. Peers, so I agree, we have tons of great examples of peer-led, peer-driven programs in Vancouver and elsewhere in Canada. Yeah, including at YouthCo and HIM. And I think that these are important, first and foremost, because some people, in the context of stigma and in the context of having had negative reactions from some healthcare professionals, might want to start with peers. And what I know from clinics, STI clinics in London and Amsterdam, who have done a lot of work around mental health service integration, is that in particular for substance use, they find it's more effective to get people into whatever the referral pathway looks like if it's starting with a peer who has lived experience with substance use. And that might also be true for other health issues as well. So absolutely, I think we have to do it, and we can do it, and let's talk about it next year. Thanks, Sarah. Yeah, hi.
Hi. So great presentation. I just, as I go to conferences and we talk about the determinants of mental health and all the things that impact our mental health, I also think it's really important, and this isn't something you didn't do, but I think it's like a larger system thing. I wish we had a system that didn't look at mental health services or psychotherapy as problem-driven. So like now I have a diagnosis, now my depression's really severe, and now I'm dealing with something that warrants talking about it. Because there's value in that, of course, but I think mental health can be like, I think there's an opportunity for it to be much more exploratory, right? So we all have a mental health, and there's so much to talk about. And how does our mental health and well-being shift between different settings, different times of day, who we're with, when we're high, when we're sober, right? It's not like this. It's not a static thing. For some people, it can be long-term. And so I just like one of my dreams is that we can be in a landscape where mental health is more exploratory, and we think about everyone having a mental health way before we're thinking about it as connected to outcomes, where the indicator is like a physical health concern or like suicide risk. So I just wanted to add that. Nothing you said wasn't good.
Yeah,
so
thank you for making that point. Yeah, I completely agree that, in fact, almost everything that I'm talking about is happening far too late in the process. It's happening way too late, and we can start to make it happen earlier, I think, through places like ambulatory care, STI clinics. But yeah, by all means, this should happen before someone's even identified the issue. I think we're just talking about the tip of the iceberg here. So another session for next year at the summit. See, Jody, I'm like already scheduling the summit next year.
Making my job easier.
Okay, well, with that, I will hand it over to Jody, and thank you for your time.
Well, thank you to John, Alexandre, and Travis. That's exactly how we wanted to end today. And so thank you, all three of you, for delivering. A couple of housekeeping before we go out the door. Just a reminder, we have Community Connections tomorrow from 1 till 5 p.m. at XY. We hope you'll join us for that. Also, there were a number of different presentations because there were 3 rooms running almost simultaneously throughout. This room, 1900, and room 1700 were both recorded, so it will take us a little while to write up the proceedings. We actually have had volunteers in the audience for each session writing a proceeding, and so that will be available online with YouTube. So if there's a session that you didn't get to see or there's one you want to share, then please do access that. We'll send out that link to everyone who's here once it's created. Also, if there's a particular presentation that you saw that you need for your work, if there's some evidence or something that you really want to get your hands on, that's what this summit is about, right? We want to affect change. So please feel free to email either myself directly, Jody with a Y at cbrc.net, or you can email Michael H at cbrc.net and ask for a specific slide deck or information, and we'll help facilitate that. If we don't have it, we'll reach out to a presenter for you. So we'll commit to that. Also, evaluations. We're going to pump out an email probably within the next 10 days asking for your feedback on the summit. We read those things and we listen and we try to impact change. So adding more Indigenous content, reaching out to other communities, adding French to our summit, adding a 3rd day. Those are all things that you told us. And so we're trying to evolve with you and we want to be responsive. So please do take a moment to fill out those evaluations because they matter. I want to end with thanking our presenters, our moderators, and my team at the CBRC. I want to thank all of you for coming. Several people mentioned to me over the last couple of days that it's a bit like a reunion or like a family get-together. Many of us work together or we see each other once in a while, but I hope that we strike the right balance here at the summit of creating a place where we can learn something, educate some people, but also have a bit of fun and really feel our community. Damon, you made me tear up today. Thank you for that. I got the feels. You too, Travis. So thank you both. It's nice to connect with that. I want to end by thanking our funders, the Public Health Agency of Canada, Heritage Canada, and the Ministry of Health. Thank you, everyone, and I hope to see you tomorrow.